So there are three ways to perform minimally invasive surgeries. Of course, there are more than three, but what I found that the most effective, repeatable, and then safe procedures that you can perform at any environment, the surgery center, hospital, but then more than anything, you can perform this in office-based surgical suite. I'm going to share with you more in depth reverse Austin type or reverse-Chevron V type osteotomy of first metatarsal cut that I regularly perform in my practice for the patients who have a bunion deformity. I explained to you three ways to perform minimally invasive bunion procedure. One is the bump plus possibly with or without akin-type osteotomy. Second, one of my go-to minimally invasive bunion procedure, which is the Reverdin-Isham osteotomy that has been performed thousands times and also published in numerous articles for its effectiveness. And there are some comparison study articles. Again, if you want to learn more about this, please communicate with me by leaving a comment below or send me an email. Everything's in the description below. I'm going to focus on the reverse V type osteotomy. So I want to share this presentation for you because I want to provide more values and more information, resources, so that you don't have like shades on yourself. Oh, minimally invasive surgery is something that you don't want to do. I want to educate you by providing this type of high-level masterclass that you can understand more about why minimally invasive bunionectomy, it's been evolved and improved over past 50 years, and now it's been performed all over the world. So following my introduction here, you will learn more in depth about reverse V Austin type, the minimally invasive bunion procedure.
Welcome to the Podiatry Profits Podcast, where you will discover how to get more patients and multiply the profits of your practice with minimally invasive foot surgery, proven marketing systems, and ethical influencing to your patients. And now, your host, board-certified podiatrist, best-selling author, speaker, and founder of TJ On Coaching and Consulting, Dr. TJ On.
We are going to talk about reverse Austin, for how I learned and how I have been implementing the reverse Austin, and then bonus, because I'm going to share you guys that live case I recorded, the one that I did yesterday. And obviously I did combination of reverse Austin and akin, so you can kind of look at it. It's a live, uncut, so you can see how typically how long it takes. Okay, so yeah, where I take the most time is when I dissect it and then bump off. When I take the bump off, in and out to in, that's where I spend most time. And then actual cut, osteotomy cut, is pretty fast. Either hammer toe or lesser met or first metatarsal. Although you'll see at the live case demonstration, I forgot to tell my staff to do first part of dorsal cut after pilot hole. So that part is missing. But you'll see the angle. I kind of re-demonstrated little bit so you guys will see how it looks like from outside, because reason why I don't do invite doctors to come to my office-based surgery and then because I get a lot of requests, can I come shadow, can I come look at it? So my answer after the years is no, because you guys may have to adapt my idea too. More than half of them will get so scared and afraid more when they see how we do it without having knowledge. They're gonna get scared, and you are going to basically scare them away, and then it's almost like disservice and negative effect. So I'd rather bring or invite anybody who's serious, committed, have enough knowledge and some experience, then we'll talk. But a complete newbie or complete like traditionally open surgeon, trained open surgeon, I don't even invite them. They don't need to see it, because if they see it, they're gonna learn nothing. They have to come to cadaver lab, and they'll see, feel with their hands, and then if they see someone else who's good at it, proficient at it, then they can appreciate it. And number two reason why I don't invite people is because I'm doing on real patient, and this is different from open surgery. You really have to focus. It's not the time to show off and then distract yourself talking to someone. We have one cut to make, and then I want to have like 100% focus. So even recording, have somebody record my case, that also like stresses me out. So, I don't know, some of you guys may not consider or think this seriously, but that's how I generate great outcome. I just 200% focus, intense focus. So after usually 2 to 3 cases, I get so exhausted mentally. And I know most of you guys who do back to back, you guys know what I mean. Physically and mentally get really tired. So what we'll be covering, when to choose reverse Austin. Number 2, I'll show you the sawbone demo. And number 3, a concept of making a plane with MIS rotating osteotomy burr. When I write op report, I learned this from Dr. Adler. He called it rotating osteotomy. It's a nice term that we are making osteotomy but rotating burr, but a lot of people think rotating burr is making like holes, but for us that's our instrumentation to make cut osteotomy. So that's maybe a little pearl for some of you, and I will show you obviously that case recording of live case of reverse Austin that I performed yesterday. So section 1, when to choose reverse Austin type osteotomy. So I'd say moderate to high IM angle for me, because mild to moderate with the PASA, as you guys know, my go-to choice is always Reverdin-Isham. So when I see a pure IM type of deformity, like a wide, and then I know I'm going to break the lateral hinge. If I choose Reverdin-Isham, then I think about reverse ostomy. Let's say if you need to plantar flex a bit, step down osteotomy. Hallux rigidus and hallux limitus type, you need to create a joint space type. That's when I usually choose reverse Austin type of cut. Again, not too high PASA, not too big bump. I put it there because if it's mild to moderate bump, and let's say you don't need to correct PASA, but I am more than PASA, I choose reverse Austin and not even bothering to shave the bump. If a bump is big, then you can shave little bit, and then because you'll be shifting, and then it will prevent having that little ledge at the cut area, right? If you shave off too much and you laterally shift too much, and then you'll have to deal with that little ledge where you make a cut, and you may have to use manual rasp, or you may have to really control the 3.1 or 4.1 and then right around the ledge and try to remove it, because sometimes patients later complain about that area if it develops like secondary bone callus around it. So sawbone demo, what I'm going to do, let me see if I can share another screen. So I have a sawbone demo. Most reverse Austin, if they have moderate bump, you don't even have to take the bump off. That's one beauty of it. But I still, release the capsule around it. So when I do the reverse V, shift it, sometimes those medial capsules too tight, and they're pulling that distal fragment back to where it was. So I still like to go around and loosen up the capsule. But if a bump is not big enough, you don't have to shave off the bump or in to out to melt the bump. You can just immediately go to clean up the passage and capsule, and then you can do the reverse Austin cut. So from here, so incision is about a little bit more center. So you kind of get rid of this you know. Again, be careful, extra careful about speed, right? Your speed of the burr, that imaginary incision site, that you can kind of let them stretch this out, right? But reverse Austin, we still want to stay somewhat inside of intercapsular. There's a natural capsule, and then you don't want to do too proximal. So your first pilot hole is going to be right where probably capsule about to be end. So that's somewhere around there you want to go. Now, imagine if this pilot hole, we're going to create in the middle of it. Pilot hole is angled this way. I'm exaggerating. This way, and we do through and through cut. If we shift this distal fragment to laterally, it'll shorten it, right? And then when you make a pilot hole this angle, when you shift it, this most likely lengthen it. So you want to kind of stay in the parallel to the long axis of first metatarsal. So you will, somewhat stay in control, not too much lengthening or shortening. In and out, you see, I notice in and out, in and out, in and out. So you'll usually feel resistance there, and then, be patient, kind of push it in, apply some pressure, and then continue to do carousel, like in and out motion, and then it's going to pop out. As soon as you feel the give, you stop. I take it out this way, and then we look at the AP view of the fluoro like this, so you can see if you're happy with the level. Now I'm going to share a very important concept. A lot of doctors have issues. Osada drill burr, metal doesn't bend. Look at my
So when you
face,
do
it's got sawbone dust.
osteotomies, let me use this one. No, let's just use this one just for demonstration. This is obviously not Osada. This is bone reducing burr. When you lift it up, when you're making a bone cut and trying to lift up this way, like parallel, bone doesn't cut. It's not lifting it up. It's creating line. You make a line. You see, this is a line, not plane. And then if you make another line, this much plane has formed. If you make another line, this much plane has formed. Another line, this much plane. So you see, I created this plane by not lifting it up, making bone cut with, long Isham burr or short Isham burr, one line, making pressure on the other line, making pressure on the other line, as I rotate it, obviously. You see, like this. So I'm making multiple lines in plane. So as you make a line, like infinite lines. Does that make sense, guys? Almost like a mathematics. Infinite lines to create this plane, not lifting it up. Continue. This is reverse Austin. You want to create a reverse V. Reverse V. So there's a V angle here and gentle V here, almost vertical here. So I don't know if you can see it. There's a little bit of V, and the bottom is more vertical. Again, reason, instead of linear, like a Wilson Reverdin-Isham style, if we create a V, when we shift the head, it's more stable because it's a V, it locks it in there. Angling it, I'm not parallel lift it up. So I came out of here. So what I created is that much plane by making lines on this side. Go toward the center. You see, I'm going to the center. Are you like highlighting it, getting closer, so they can see? Okay, so now I'm aiming for dorsal medial. See? So I finished that V cut, and obviously dorsal medial, there's a lot of still cortical bone there, so don't lift it up. Idea is, again, gentle speed, trying to create that multiple lines to create, passes through the other side. Now I'm going to create kind of vertical plantar cut. I'm going to aim for lateral plantar, just like how I explained. Right there is more cortical. But anyway, that's, once you finish, you'll feel the give. So here's why we don't want to take too much bump out, because once you shift it, if you take too much bump out, there's a ledge. This ledge usually smooths out, so I don't even bother, but you can potentially use the rasp. You can use a rasp and then smooth that part. But here's the idea now. It's a V cut, and then you can shift it, and then you can lock it in by doing akin, adductor tenotomy, crank the toe, and then lock it in to put it in here to fix the bunion.
Grow your practice with me by liking my video and subscribing to my channel. It helps me tremendously, and then also it keeps me, producing videos like this for you. So let's go to, what we're gonna cover next, recorded live case, reverse osteotomy, and then akin. It's I included that anyway here. Akin after that, and then you can see kind of how I manipulate fluoro, during the procedure, because some doctors ask me how you move, how you manipulate fluoro during the procedure, and then immediate post-op you'll see. And I don't like to keep it live too long, just for your own benefit too, less exposure to the less exposure to the radiation. So trying to use quick burst, and then do like pre-op, yes, and then I take picture, I save it, and then print it, and then like right before I make some kind of major cut, I want to make sure with the mini C-arm. And then sometimes, like if I shave off the bump, I do several quick bursts. I kind of want to see where we are now, right? So, don't be afraid to use them. At the beginning stage, you'll use a lot, because we're nervous. Are we sure? Are we cutting the right plane, right area? So it's okay to use it. Supposedly, mini C-arm has very weak radiation. But you'll be doing hundreds of this, so I recommend you to use lead gown. So I use lead gown, and then thyroid guard, because we just use it every day. Every week. So here's the pre-op. I did a little pre-op so you can see. Here we go. Okay, May 13, 2021. Here with my patient. Pre-op. Minimally invasive bunion procedure. Little incision, 1, 2, 3, and then I'll do the correction of this bunion, and we'll shift the bone, and we're not going to use any internal metal, and patients will walk right home with surgical boot. We don't need any crutches. And that's it. It'll be under local anesthetic and my office-based surgery suite. Any questions? No? Okay. So this one was performed by another another foot surgeon, but it was done with a screw fixation and traditional open procedure, and she went through some complications. So on this foot, we're gonna do with a minimally invasive approach. This incision made it a little bit diagonal than typical, that I make more horizontal, but when I wanted to extend it a little bit to reach the capsule to dissect it, I extend it slightly diagonal direction, so you'll see that incision's not really horizontal, but again, it doesn't make big difference. It's only 3 millimeter.
Okay, so we can go to the original pilot hole.
So pilot was already done, and then dorsal lateral cut was already done. So I'm going to dorsal central and then dorsal medial here. Look at the angle of Osada drill.
Okay.
So that one
Okay.
was like dorsal cut, but obviously
Finish the plantar.
plantar, I think I show you whole live, so you can see. That's a pilot hole. Notice quiet speed and do in and out. So some bleeding like that, that's normal, okay? I usually put stack of gauze on the I didn't cut, so I like to go in there and then try to finish that last ledge there. And then you'll feel the give with your left hand. So I felt the give. You see that little bone paste coming out. So that much shortening, 2 millimeter or so. So now I can feel it shifting.
And shift the head.
So you can see on the left hand, the big screen, it shifted nicely, you see it? So incisions right there. You notice, you can still mark it, right? You can mark, and then so you'll see the level of the base of proximal phalanx. I'm going to plantar area, like make sure I create a portal there. Plantar and dorsal around the incision site. I extended it. Making a pilot hole now. Watch how I try to find the center point. Up and down a few times. So I can feel that about the center is about there. That's how I usually find the center. First initial cortical, it's a little bit tough bone, so I speed up a little bit and then slow down the speed. And then I feel the lateral hinge there, a lateral cortex, I stop. I like it. I gotta be careful. It's a little bit closer to the real base, so I want to make sure I didn't make another hole, so I just stayed there. Because this type of proximal phalanx, right? So you guys see, this is as real time as it gets, and it's really like total video is 3 minutes of cut, because the last 1 minute is post-op video. So again, making lines to create plane. Dorsal's done. And then I clean the tip. Make sure, you gotta clean the tip as often as possible so it doesn't trap all the bone debris and, making unnecessary burning of the bone. Now I go back to the pilot hole, to the lateral hinge, and then I create, leaving the hinge, I go aiming for lateral plantar, and then going for plantar, and then medial plantar. So you can see the black portion of the Osada drill getting lifted up within that limit of stretching area of the incision. It kind of slide off right now, so I put it back in, and then I know the medial plantar is still attached. And notice my non-dominant hand keep pressing it to create a wedge. So it's done.
Okay, so this is post-op. We're gonna, no internal fixation, lock the toe, osteotomy, and bandage it this way, but it'll look really nice once we load up. This part will, so this is a reverse Austin and akin-type procedure.
Beautiful result.
Thank you.
And we're gonna put bandage on, so this looks really nice.
Okay, so that really concludes the video. I hope you learned more about reverse V-type osteotomy, and then, hopefully, you're more aware of different types of MIS procedures. Now I do have, the MIS mentorship program, which help you learn and implement, coupled with, private group cadaver labs I run 6 to 7 times a year, so that not only you learn the theories, but, I actually provide the environment where you can have your own cadaver lab to work on and improve your skill set through my mentorship program. So if you're interested in learning more about this program, there should be a link below, and then we'll connect and then we'll communicate. Now I also have a free group specifically for podiatrists and aspiring ones who want to up to date, who want to evolve to modern healthcare environment that you don't learn at the school. So in this free group, we share a lot of knowledge and information among colleagues, and again the students, residents, and fellows in there, exchange information, and then you kind of really understand the real world podiatry and how you can survive and thrive in this new environment. Please look at the description below. There should be a link, and join the group, and I'll see you in that group. So again, I'm going to tell you one more time, please like my video and subscribe to my channel so that you don't miss out my newly weekly updated new videos into our channel, so you can always educate yourself, learn the possibilities, how you can be happy podiatrists and foot and ankle surgeons and serve many people in public health.
You've been listening to the Podiatry Profits Podcast with Dr. TJ Ahn. To find out more about Dr. TJ Ahn or discover how you can grow your podiatry practice, visit drtjahn.com. Or you can also get a free copy of Dr. Ahn's best-selling book, Opt Out: How to Take Back Financial Control of Your Private Clinical Practice Without the Hassle of Insurance Companies. Just go to optoutbook.com.